So in regards to the RET space that you so eloquently spoke on, what are your thoughts about Selpercatinib versus Pralsetinib?
It's a good question. We get that very often from our patients. I tend to think about them as interchangeable. They have equivalent efficacies. They have very similar side effect profiles, and they have basically equal tolerance among patients. And so the only difference that I see is just in the schedule of giving the medication. And so I think that either or are perfectly fine to use in patients who have RET mutated non-small cell lung cancer.
Thank you. Yes, I agree. Any thoughts about CNS penetration or in that same space, just kind of piggybacking off the same question?
So I think there is intracranial activity for both medications. I think the Selpercatinib trial did demonstrate very effectively that in a group of patients who even had multiple lines of prior therapies and had targeted measurable disease in their brain, they were able to show really deep and long responses. So for patients who have brain metastasis that is not symptomatic, meaning that is not causing seizures or weakness or focal neurologic deficits, I tend to even avoid radiation for these patients and use these medications, oral inhibitors, to control their intracranial disease. And I'll just also put a plug for patients who have no brain metastasis at the time of their baseline diagnosis who are on treatment with RET mutated non-small cell lung cancer to be screened periodically with brain MRIs, because that is one of the ways where cancer can kind of sneak up on you, and you would want to know about these resistance mechanisms before they actually cause problems.